Dr. Steves, what has been your experience with efficacy and safety of the oral agents versus IV in terms of best practices for improving patients' adherence? Any differences that you specifically point out to patients with regards to administration?
Right. And definitely, I think a pharmacist, one of their biggest roles in these oral oncolytics is the stressing how important adherence is. I think we have data from CML that will tell us how important it is. Just a small decrease in adherence can lead to a large decrease in the, or large increase in the chances to, lose your complete response in that disease setting. And I would imagine if we did the same data in CLL, it would show similar results. But we always know that efficacy and adherence are kind of tied hand in hand. You're going to have less hospital stays, less progression of disease. You're not going to have to move on to another therapy, things like that when adherence. So as a pharmacist, it's really important to educate the patients on this adherence, starting with the first conversation. I think this is one of the hardest things for a doctor's office to manage. They can't watch a patient swallow a pill every day. If the patient has 6 cycles of chemotherapy, they either came or they didn't. So we know if they got their IV chemotherapy, but doctors can write a prescription for a 6-month supply of a oral agent and just kind of, hope and pray that the patient's going to take it every day and hope that the pharmacy can manage that accordingly. So as a pharmacist, it really starts with the discussion of how important it is to schedule it, how important it is to call the pharmacy, call the doctor's office, call your nurse, call whoever you need to if you're having a side effect, and see if we can help to manage it rather than just stopping the drug for a couple of days on your own or something like that, and really try to avoid these holdups in therapy. Efficacy data, I think, with all the agents is really going to be pretty strong. I mean, it's a disease that's not a extremely difficult disease to manage in most cases, especially our IGHV mutated non-17p deleted patients, but tolerability just becomes a major concern. So, our frail patients or patients with multiple comorbidities are going to have a lot more, harder time. It's going to be a little more dangerous to give them those higher drugs. So the safety of giving those patients IV chemotherapy should always be discussed. And that's why the NCCN, I believe, recommends not giving that FCR in those 65 and above or those frail patients and sticking to the oral therapies. Additionally, even when you consider the safety of the IV chemotherapy, even in younger patients who may get the disease, maybe in their early 50s and may have many decades of life expectancy still, some of the data has told us that they will increase their chance of secondary malignancies, not even just non-melanoma skin cancer, which we know is pretty well tied to CLL, but any secondary malignancies up to double, maybe 2.5 times in their future decades of life. So, and then just going to the actual administration of the 3 primary NCCN recommended therapies, they're all kind of different in their own right. I mean, venetoclax is administered with food, same time each day. Acalabrutinib is BID, and so 12-hour spacing and kind of getting patients adherent to that regimen is important. And ibrutinib is once daily and with a full glass of water. So kind of keeping patients on track with adherence is very important. Venetoclax has its own set of adherence challenges because they need to adhere to their medication, their doctor's office visits if they're not doing it in the hospital. So they can have TLS measured early on at the start of therapy. So they all present their own unique challenges. And it again, all loops back to the discussion we've had of patient-specific factors and choosing which patient is the best for which particular therapy. And I'd love to hear your thoughts too on anything.
Yeah, no, I think that's very helpful. I definitely agree with you. I think in terms of improving adherence, I think working with the patient early on to assess what's worked for them in the past, what challenges they've had in the past, who helps them with their medications, how to incorporate that into their routine has been a really helpful, I think, intervention. If I know I found that if I'm strapped for time, at least figuring out exactly how to customize that to the patient's lifestyle has been really helpful in my practice. And I think plenty of adherence studies in oncology or otherwise to support that intervention alone can be can be really helpful. So I've really latched onto that. And so in terms of really asking patients number of doses they've missed within a really clear period of time, a week or 2 weeks, we found to be helpful as well, and that's supported in the literature as well, I think. And then really having a process in place to trigger what what a problem is with adherence. So we usually use the adherence metrics from the CML tyrosine kinase inhibitor data of 85% adherence or 2 or more missed doses in 2-week period. And I think building that into the adherence tracking process, whatever that looks like, if it's individualized or system-wide, can be really helpful. I definitely agree with the oral administration differences. I think that's one thing that I found might get forgotten or missed in the large picture of education about maybe a new stage or new diagnosis. And so I think as pharmacists, I definitely agree with you. I think a huge thing that we can do is help patients with administration. Also with acalabrutinib, avoiding acid suppressive therapies because of that acidic environment for absorption. So the other thing that I think is really challenging as we're combining these therapies is, what do the administration differences look like for oral versus IV therapies? And I think it becomes really challenging when there's so many different stakeholders involved that may not be involved in one or both of those oral IV dispensing processes or insurance approval processes. And so we've really tried to figure out ways to create a clear communication plan, at least for the family and patient, so they know exactly what therapies they're getting and when. Because as we already mentioned, I think the schedule and the duration and the frequency and the dosing for both agents, now that we're starting to combine 3 agents in some of the trials, it becomes really complicated. And so that can really, I think, throw some wrenches in there from a safety perspective and an adherence perspective to appointments. So it can get so complicated and can be a huge stressor for patients that I think we can all help to try to alleviate.